The one used in the UK?
Beverage.
Yes.
Okay. This all started with Lynn asking me, is this a Bismarck model or a Beveridge model? Those are theoretical models, okay? I mean, they're not exactly theoretical. That Bismarck created a healthcare system 150 years ago, and Beveridge created a healthcare system 90 years ago, 80 years ago, whatever it was. But if you look at the healthcare systems of the world, they aren't pure. They aren't pure Beveridge, they aren't pure Bismarck. Very few of them are. They're somewhere in between, and they keep moving back and forth. Okay, so to put it simply, the Israeli healthcare system has components of the Bismarck model and components of the Beveridge model. So universal health care, that first level of care, that would be a Beveridge model. The fact that most of the health care is provided by government hospitals, and that a lot of the salary of physicians comes from the government through taxation, that's a Beveridge model. The fact that you have an HMO is not a Beveridge model, that's more Bismarck. Okay, so there's an intermediary. The fact that people pay through their employers, their employer contributes, that's going to be more of a Bismarck. The fact that you have 4 levels of care, certainly the 3rd and 4th level of care are going to be more privatized or Bismarck. Okay.
So it's not a national insurance system.
That's way too simplistic.
Yes.
But there's universal health care. Okay, right?
But I mean, so if you want to look at this, like, I mean, Switzerland, for example, everyone needs to be covered, so there's actually also a universal.
Yeah, but
Like,
Switzerland is much more Bismarck.
No, I know, but this definition of universal health care, I mean,
Right.
is also more complex than just
Yes,
the government
that's right.
gives everyone.
So-
If unemployed, you are still covered.
You're still covered, okay? So, to go back to that line that I drew, from socialist to capitalist, when Israel was founded, it was founded by socialists. And the healthcare system was a Beveridge model to begin with. And then it's been moving more or less to the right, more and more toward Bismarck. And, you know, you have a right-wing government here, and they're continuing to try to privatize as much as they can. That's their philosophy.
Thank you.
Okay, thank you very much.
Okay, I hope that helps.
Yes.
I did email everyone an article from the New England Journal, it's I guess 7 years old now, on the Israeli healthcare system, just now. I mean, you've gotten it in that whole big mass series of emails that I sent, but I just did it again this morning, because I asked you for some information. Okay, Tegan, you ready?
Yeah, I guess so.
Okay. I need to give you this. Okay? Yeah, that should try it. Let's see if it works. Just a second. Batteries popped out.
Something
Sure.
managed care, what is that?
In the States.
Okay.
Not in Israel.
Huh?
In the States.
What is the
Huh?
Managed care, that an intermediary decides if what the doctor recommended is appropriate and if the insurance will pay for it.
What is that on that?
The managed care organization.
Okay. So they tell the doctor what to do, is that?
Yeah, the doctor
I think four.
has a list of procedures you can do. But for certain procedures, you have to ask permission from the managed care.
So as to reduce cost, I think.
Exactly, it's a way to reduce costs.
Do I have it in here?
It's done as a private.
Eso no me gusta. אפשר לעשות את זה בתחומים מסוימים. נעשה את המשקיעים, כן, זה. בביטוח יש ביטוח סיכון. כן,
Okay, try it now.
so בכסף.
Okay. It just happened. Okay, so, well, I'll put employment if you need.
It's working on here, but not here. See, I can move it on your screen, but it won't move on the screen.
Let's try this.
Yeah, I can do that too.
Okay.
Yeah, I'll put them on.
Is that like a universal video?
Yes,
that you
that's
use?
fine. Yes.
Okay, I was very
I mean,
curious.
Yeah, you can use mine.
Yeah, I don't care, unless somebody else cares. Okay? We'll find out. You are scheduled to go next to 11:30. Is that okay?
Can I use that USB?
Is there a pointer application on the cell phone?
I turned it off.
Ah.
no, it's just.
Yeah, I was like, really?
Yeah, so basically.
Impressive.
Even what is that?
I used it once already.
Yeah, but what is it?
It's like, no, just sign it.
There's one
I would bring this to the station to have a keyboard. Does your computer still work?
Well, I submitted it, so I should be getting it this week.
That's good. Are you using this room though?
Yeah, I mean, I use it anyway. Mac, PC, what's happening?
That's good.
Okay, so you're gonna use this, right?
I don't know. Let's see. Let's just see what this does.
So high tech.
No, I told you about doing that, Kingdom. I left that out on purpose.
Okay, try.
What's going on here?
You can try the button.
Which one? This one?
Yeah.
Yes.
Oh.
Okay. Thank you. Alright. So, I do the healthcare system in Thailand. So a little bit about it. It's located in Southeast Asia and it borders Cambodia, Laos, Malaysia, and Myanmar. And the population is concentrated in a lot of the urban centers like Bangkok. So it is a constitutional monarchy, which essentially means that they have a parliament and in order for any of the bills to pass, the king has to sign off on it. And if he doesn't, it can be brought back to the system by the prime minister, but if he still doesn't believe in it, the bill won't pass. And the Ministry of Public Health oversees the entire healthcare system. So the GDP is $406.84 million. The population is around 68.7 million. The official language is Thai, and the main religion is Buddhism, and that's about 94.6% of the population. And the currency is the Thai baht. So a few general figures. So life expectancy at birth is 72 for men and 78 for women, and the total expenditure on health percent of the GDP is 4.1, and the maternal mortality rate is about 216 per 100,000 women, which is pretty high. And so the top 10 causes of death you can see here are non-communicable diseases, and Thailand actually has the 4th highest death rate for road injury in the world according to the WHO, so they're really trying to deal with that and decrease it through various like safety campaigns and stuff, but it's still quite high and it continues to be on the rise. So the population, it's predicted by about 2030 that roughly 15% of the population will be elderly, and the fertility rate is also relatively low, so the population's aging, and a lot of the health funds are going to have to deal with this in the future because they don't have a lot of systems for the elderly right now, because it's also a traditional family model. Once again, your family's expected to care for you once you get older, which is pretty similar around a lot of Asia. So, a timeline of healthcare services. So, in 1975, the health services were made available to the poor free of charge, and in 1982, there was a freeze on capital investments for urban hospitals, and this was because there was a real disconnect between the healthcare in urban centers and the healthcare in rural centers, where most of the doctors are concentrated in urban centers and not a lot are in the rural centers. So the money that was typically sent to urban hospitals was then filtered to the rural centers to improve services. In 1997, access to healthcare included the National Social and Economic Development Plan, and then in 2001, universal healthcare was achieved. So prior to this, about maybe 1 in 4 Thai people actually had access to health services. So an overview of the health system. The Ministry of Public Health is the National Health Authority, and it's responsible for formulating, implementing, and monitoring and evaluating all of the various health policies. And then they also have the Health Systems Research Institute, which was created in 1982, and it generates knowledge and increases policymakers' demand for high-quality evidence to guide decisions. And then they have the Thai Health Promotion Foundation, which I think is really interesting because they introduced a sin tax. So the revenue from tobacco and alcohol is used to fund campaigns on a wide range of issues that are designed to promote and protect people's health. So they're trying to get you to stop smoking by taxing you on it. The National Health Security Office manages the Universal Care Scheme, which is the main scheme that I'm going to talk about that the majority of the population uses. And this includes the annual budget negotiations, strategic purchasing, the benefit package, audits, and ensuring that healthcare providers are accountable to the Universal Care Scheme. So, a couple more things that they got. The National Health Commission Office ensures that public policies, including health policies, are participatory and they engage in all the actors throughout the country. They have national health assemblies, and then they also have local assemblies to determine which of the different areas needs and to see how the budget should be allocated to them. And then they also have the Emergency Medical Institute, which is responsible for the management and financing of pre-hospital care and ambulance services. And then finally, they have the Healthcare Accreditation Institute to mediate and improve quality of care, but also to accredit or re-accredit institutions that have lost it in the past, and this is for public and private healthcare institutions. And since they created this, a lot of the mortality rates have actually fallen. So, the insurance system. There's 3 different kinds of insurance in Thailand. There's the Civil Servant Medical Benefit Scheme, the Social Security Scheme, and the Universal Care Scheme. So here's kind of a breakdown of the 3 different schemes, which I'll talk about a little bit more. As you can see, the majority of the population uses the Universal Care Scheme. About 8% uses the Civil Servant one, and 60% uses the Social one. And it's all paid for through general taxation, except for the Social Security Scheme, and that's like a co-payment system where you, your employer, and the government pays for it. Okay. So I'm going to talk about the Civil Servant Scheme. So it's administered by the Comptroller General's Department, and it's, again, funded by general tax revenue, and it covers about 4.41 million people who are eligible for it, and you are eligible for it if you are a civil servant, a permanent employee, a pensioner, or a dependent. So the Social Security Scheme is primarily intended for private employees. That can be foreign workers. About 11% of the population uses this, and as I mentioned, it's a co-payment scheme. And then lastly, the Universal Healthcare Scheme. So it covers the majority of the population. It's entirely financed by general tax revenue, and it provides services to those who are not enrolled in the 2 former schemes. There is no fee-for-service or co-payment required. Originally, they did try to use a fee-for-service, but it actually cost more to collect the fee than the amount of money they were making from the fee, so they discontinued that. And then also, due to its geographic location, there is a large inequity in health services, with the majority of the services being located in urban centers, which is a problem which seems to be like all over Asia and a lot of the world. So, funding. As I said, it's funded by income taxes, but more obviously for the poor than the rich. The rich are paying for a lot of the population. So the users paid a co-payment of about 30 baht, which is 70 cents USD. And the budget is determined by the number of beneficiaries multiplied by the standard per person rate. So roughly $80 USD per beneficiary is what each person gets. In terms of budget allocation, each scheme is separated through a purchases provider split, and they manage a demand-led system of financing. So, the medical system. There's about 2.9 beds per 1,000 people, 1.5 physicians per 1,000, and nurses and midwives were put together, sorry Linda, 3.2 per 1,000. And again, concentration of services are in Bangkok, Chiang Mai, and Phuket. I know, they were given numbers for just midwives. So the health delivery system, you can kind of see in the chart, most of the people will go to regional hospitals or provincial hospitals if they're under the universal care scheme. If you need to see a specialist, you will be sent to a university hospital or another public hospital, but it is a referral system. And then if you can afford it, you can go to a private hospital. But most people don't get private insurance. It's just not really a thing in Thailand because the premiums are so high and also like the underwrites are kind of strange. So most people go with the 3 national health insurance schemes. Oh, also pharmaceuticals are subsidized, so if you can't afford them, they're covered by your scheme, depending on which one you're in. They've done a lot of reforms. They've introduced health insurance cards. They've expanding to cover like a high cost for like various things like MRIs. They've increased their health expenditure primarily because the population is aging. They need to work on the burden of chronic care. Yeah, that kind of sums up for that. So achievements and challenges. So universal healthcare for 99.9% of the population, I would say is a major achievement. One of the main challenges is that education has failed to meet the needs of the people. There's a huge demand for doctors and nurses. So they've started a community nursing initiative, and so they say roughly they need about 9,000 more doctors and 43,000 nurses to address rural shortages. So they've created a program where they go into rural communities and they see who is excelling academically, and they offer them special incentive packages to go to school and learn to become a nurse, and then go back and work in their communities. And they have a similar program for doctors. Only about 5% of physicians become family doctors, so there's a real lack of GPs. Nobody really wants to go into it because all of the money is in working privately or getting a specialty. And then another achievement is that they've erased the equity gap in infant health. It's steadily decreasing rather than increasing the way it was in the past. So, some problems. As I said, there's a concentration of physicians and nurses in urban centers. Rural provinces have about 1 doctor for 5,308 people. There's a shortage of physicians, there's a lack of family physicians, and reducing the death from non-communicable diseases, particularly motor vehicle accidents, is one of the major ones they're trying to address right now. So, has the universal healthcare in Thailand been a success? A lot of people say yes, and they're using it as a model for a lot of other Southeast Asian countries. So they say that Thailand's universal care scheme has been a success due to sustained leadership, learning from past experience, and its evidence-based, systematic process for determining which health services to cover. Yeah, that's Thailand's healthcare system.
So is Thailand a middle-income country, do you know?
It's becoming like middle to upper.
Okay,
It's one of
it's
the
upper
more
middle
developed.
maybe? There is a category, World Bank has upper income, upper middle, and lower income.
Yeah, it's actually on the rise. It's one of the better ones. Typically, if you get sick in Southeast Asia, you're told to go to Thailand because that's where the better healthcare is.
But there's what they are most known of, the Thai healthcare,
Medical tourism.
medical tourism
Yeah.
for a specific thing,
Yeah.
gender
Yeah,
changing.
gender
surgery.
reassignment surgery.
Yeah. Israel is
It's a business.
It is a business. Yeah.
Okay, I think, any other questions for Dean? I have a couple of points, but go
I just
ahead.
find it interesting that with an investment of 4% in the health expenditure, they have a life expectancy in the mid-70s. Is that a matter of efficiency or?
It's a matter of efficiency. They actually always go to the population and see what each of the different areas needs. That's why they hold the local and the national assemblies. And then they allocate the budget and they put it into programs depending on what each of the community needs. They do a lot of research into the
Less
communities,
corruption,
which
maybe?
The mortality is high, or the maternal mortality is high in infant health.
It's quite high. That's what I thought too.
Yeah.
This is interesting.
And I think also that maybe comes from a lack of midwives and nurses in rural areas. They just don't have the manpower to have safe laborers. Yeah.
So thank you. Okay, I'm what you were just talking about, I just want to restate. What you're gonna find now that, we're gonna next hear about Latvia, and then we're gonna hear about Taiwan, I think, right? Now Taiwan's a high-income country, Latvia is,
It's
Middle.
rising, it's middle, it's like rising.
yeah, okay, middle and rising. So these are in Thailand, maybe you would call it an emerging market, you probably would, okay? Taiwan is not an emerging market, it's emerged, okay, it's a high income. And I don't know if anyone is talking about really, you're gonna talk about Nigeria, I guess, on Thursday, right? Which is a complicated country, because it's African, there are a lot of poor people, but there's a lot of oil money as well. So I'm curious to learn about Africa, about Nigeria. But now we're leaving the really high income countries, okay? Again, Taiwan is gonna be very interesting. But we're now entering a different category here. And so I just wanna bring that to everyone's attention. These countries often will say they have universal health care. That is their goal. The question is, when you have universal health care and you spend 4% of your GDP, how much care do you get? And this GDP is not the same per person GDP as you're gonna have in a high income country like the US or Israel or Switzerland or whatever, right? So you got 4% of a lot less, producing what I heard Tegan say, $80 per year to deliver healthcare.
That's for the universal healthcare scheme. You get more if you're with the other ones, somewhere like 400 USD.
Okay,
And also the challenges, the health challenges are much more significant, I think, in more high income countries, because we got a lot of smoking, a lot of cancer, especially in
right,
these
okay.
countries.
So we're gonna, actually, we'll talk about that more in a minute. What is it in the, what is the GDP, the per capita spending in Israel on people?
It's 7%, and the GDP is 34,000 per capita. So it's 10%, let's say 10%.
So it's about $3,000 a person?
3,000, yeah.
$3,000 a person. In the US, it's, I think it's like $8,000 a person. Something like that. Right? Something, okay.
It's like the
Yeah,
more
it's-
expensive states. Less
Yeah.
expensive, it goes to 4. It's more.
So the point is, we've seen that you don't need $8,000 worth of medical care to get good medical care, okay? Maybe it's $4,000, that's what it would be in France, or in Germany, or in Switzerland, I don't know, it's something, Canada, right? But
Or in upper Midwest America.
Upper Midwest America, right, Minnesota, something like that. Okay, but here, we're way low on that, okay? So you're just not gonna get the same amount of healthcare, okay? Now, so where do you allocate your resources? If you're the Minister of Health,
I mean, comparisons are a bit difficult because doctors' salaries are going to be lower in Thailand,
Sure.
electricity is going to be lower, food in the hospital is going to be lower, so I think it's just, it's not a one-to-one comparison, because
That's-
all expenses are going to be lower
You're
as
right.
well.
You're right, and when you go back to our first day of class where we had the video from the Swedish guy who gave us that log chart of income, 404,000, okay, was per capita income. We saw that by the time you got to 400, you were pretty good for healthcare, okay? And it was the people who were in the 40 range who were really struggling. So if you, I don't know where Thailand would be on that chart. It's going to be somewhere middle-ish. So so Charlie's right. Everything costs less, so you get relatively more for relatively less. With that said, you still don't get a lot. So where do you put your money?
Depends on your goals as a politician, as a minister of health. It depends. Well, you're interesting. You want to change the numbers. You want to make certain population more happy. You want to look good. Whatever it's a bit difficult for a politician. It's a difficult question.
Tina mentions that they do a lot of research and they see where the deficit is, where they need more.
So one of the things that impresses me from what Tegan said is that they're putting money into a health care infrastructure. They're studying what they need. At least that's what they put on their website. okay?
It is, yeah. I mean, that was one of the campaign slogans for the party after the coup. Like, it was all about putting money into the people and providing them with healthcare.
Right, so let's assume this is accurate, there's gonna be some propaganda with it as well, but they're trying, okay? And they're studying what they do, and they're committed to universal health care. They're an emerging market, they're making more money, and they're putting it in. Now, where do you put that money? Do you put it into hospitals? Do you put it into clinics, or do you put it out into community health? Biggest bang for the buck is where?
Ideally, community health.
Community health.
Was
Public
preventative.
health, right? Make sure everybody's vaccinated, right?
Mhm.
Start a smoking campaign, anti-smoking campaign. What happens is pretty variable because the elite, the power elite, want a nice hospital to go to. There's tremendous pressure to put money into medical care for people who are very sick. And from a public health perspective, that's a very expensive way to do it. And there's always this bickering and battling in every country. Okay? Low-income countries are gonna be very challenged to do that. This is a middle-income country. In some ways, middle-income countries, I think, are more interesting to study than low-income countries, because low-income countries have so little, they just do whatever they can. And I want to say one more thing about low-income countries in a minute. But one more point to make. LMIC stands for what? Low and middle income countries. Okay? NCD,
Non-communicable diseases.
non-communicable disease. What did Tegan tell us about the most common causes of disease in Thailand? Are they communicable or non-communicable?
They're non-communicable.
Non-communicable.
Like ischemic.
Ischemic heart disease, cancer, all right?
Yeah.
Now, let's go to low-income countries. Turns out, non-communicable disease is the most common cause of death in almost all countries of the world, including many low-income countries. And in those low-income countries that still have a lot of communicable disease, it's becoming less and less. The future of healthcare delivery, even in low-income countries, is non-communicable disease care. Whether it's road injury, whether it's cancer, smoking, obesity, diabetes, hypertension, that's the future of healthcare everywhere in the world.
Not in low-income countries, not like cholera and lack of clean water.
Less and less.
Less and
Yeah.
less.
And
Less
also
and less.
that's really, it's like very
Yeah.
country specific now.
Yeah, I mean, you can go, and I don't know enough about the various African countries. I
Because
mean,
of health education that is being emphasized on and preventive care, infectious disease is going down.
And HIV, no?
HIV is being controlled and treated.
Yes, it's controlled and
Sure.
In
treated.
low income?
Yes.
Okay. Actually, part of the thing with low-income countries is with the whole thing of globalization and urbanization. People are working in better jobs, more sedentary lifestyle. So, for example, even in South Africa, as much as we have an HIV pandemic, but there's been a huge increase in NCDs. You know, so in fact, there isn't too much funding on HIV as it is, because just like in the US, there's this concept of diabetes, you know, these comorbidities.
And one reason for this is also the other stretch which are coming with development and urbanization, like pollution and like a lot of people together, it's like these all are reasons for heart disease and lung problems.
I did some years ago, a lecture, and I found some interesting data. The Chinese, as we've talked about, we're all wearing Chinese clothing, literally all Chinese clothes, but a lot of the clothes we wear are Chinese. In China, they make underwear, of course, they make most everything else, and they have domestic consumption. Brassiere size in China has increased very substantially over the last 20 years.
What exactly? Sorry.
Brassieres.
Yeah.
Why am I